Vous avez sûrement entendu parler de l'Estonie comme étant un pays hyper révolutionnaire qui a tout digitalisé dans son système de soins. Donc j'ai eu l'occasion de pouvoir en parler et de pouvoir rencontrer une personne qui a été au cœur de cela. Il ne vient pas vraiment nous parler de ça, vous pourrez lui poser des questions sur ce sujet, mais de sa vision, parce qu'il faut porter une vision, même si c'est un petit pays d'1 million de personnes et qu'ils ont réussi à le faire, il faut porter une vision du futur de la santé. Je vous remercie d'accueillir Madis Tiik.
Good morning, everyone. I'm glad to be here and present some ideas what we have learned during last 15, 20 years. I'm a medical doctor. I work as a GP part-time. I do my work remotely. It means that I physically see patients maybe once a month. I have very small list. People living in Ireland, so I have a nurse who is living there, but I guide and I help them remotely, wherever I am. This is partly thanks that we have all digital solutions to do that. And it's not only healthcare in Estonia, all public services are digitally available. So I will talk you about the journey, not example as Estonia, but in more general way. And you can approach me during the day, and I can dig in deeply in different subject as you want. But then you have to find me somewhere here. So first. Every country are starting a digitalization process, establishing electronic medical record of the one institution. So it could be quite complicated and modular system like a hospital information system, which is a huge software, many components. In the same time, in this Health One level, we see that we are using, or our citizens are using different kind of devices. Myself, I have used, for example, pulse tester for my running activities since 90s. I have had several generations of Polar watches and still have. But the problem is that this device is standalone. It's not connected with my other data sets. And as was mentioned, the sick care or health care, how we say it, it's only 10% of our well-being. There is much other things that we are not looking for. And also in this first stage of technology, we are seeing already first artificial intelligence solutions like decision support or search engines to find guidelines and evidences in the medical practices. So these are there already in the very beginning. So in one word, I call this process digitalization. So people, we, doctors, patient, everyone is collecting data in digital format. But the problem is that this data is in silos. It's not shared. So let's go further to the Health 2.0. So Estonia launched their health information exchange platform in 2009 and connected all healthcare providers to share the data. Technically, it's a central repository where everyone is sending agreed amount of medical documents, and other can ask the documents from the repository. Another option of integration is that one region or all country have one software, so everyone is using the same software, and this is, for example, in PAS country and in some other places as well. So these are ways, technical ways, how you integrate things. Also, we see that big players have integrated and provided us platforms where we can connect different devices. For example, Apple has Apple Health. you can connect different devices from different producers. So you have many devices, but you have overview of all of them in one place. And also the decision support systems are more developed. So for example, as a doctor in Estonia, when I prescribe prescription, I get announcement that this particular medication could be some contraindicators with other medicines what patient is using. So this decision support or drug interaction database is already integrated in the service process. So it's integrated in my working environment as a service. So this is integration. So we have integrated, we are sharing the data, hopefully, and this is where most of the countries struggling at the moment worldwide to get this integration done, to flow the data, mainly focusing to the medical data. So this is how healthcare is looking now. So I use this study to explain this vision. And in this study, adults in Canada were asked how often they have health-related problems. And 800 from 1,000 said that yes, they have had some health-related issues during last month. So what happens next? 329 of them decides that this is so severe and they become patients. They will choose to visit doctors and they start the circling inside the healthcare system. They will they get diagnosed, they go to laboratories, specialists, primary care, and finally, hopefully, the data is collected to the electronic health record system and can be shared. So this is how the healthcare is working today. Even if we have 20 years of experience, we haven't changed anything in the process how the healthcare is delivered or how the healthcare is pursued by the citizens. So my question here is, what about those 471 who had also health-related problems, but they didn't visit the doctors? Were these 329 the right ones who entered to the healthcare or sick care? And what were their problem who didn't go there? So we don't know that because we are not collecting this information. We are focusing only the sickness episodes and collecting this sickness episode data to the electronic health record system. So let's assume that we can do in better way. And let's assume that all these 800 or 80% of us, every time will they have some health-related issue, will start to find solutions with themselves, with help of different types of AI solutions. It could be symptom checker. I have in my mobile phone at least 3 different symptom checkers. Then I can extract my data from previous cases, what has been with me in my medical records, if I can access to this data. Then we can use analytical services. We can triage these things, and finally give some advice and recommendations. Of course, some of those from 80% needs to go to see medical services. But is it necessary then to go this kind of hierarchic system? Primary care, secondary care, tertiary care, laboratory with referral. Maybe the solution is go directly to the service which is the closest or can solve the problem which is currently there. And the healthcare facilities are sending data to the electronic health record as they do now, but there is a lot of other services. And sometimes it is enough to say that this is nothing serious. It's just a physiological situation. You have overworked. You have been running marathon last week. It's normal that you are a little bit fatigued. Why you are going to see your doctor? There is no reason for that. Please take some extra rest and then come back if it is not helping. So there is a plenty of different types of services which are outside of sick care and can also influence to our health and well-being. So hopefully these data can also collect it to the so-called personal health record concept or wherever. The important is that we have access and control over the data. So somehow now we should link these data sets together. And as I mentioned, that only 10% of the data in the future is coming from the electronic health record system. Most of the data is coming through these other services. And there should be some kind of connecting point, like your personal health account or something similar. So then you can feed the AI services, and there is a lot of more data than just coming from the electronic health records. So this is the model of Health 3.0. If it happens, we need to pre-fill some preconditions. And first precondition is that the data ownership. This data is about us. It also belongs to us. At least we have to have right to use the data for our purpose. So data ownership is extremely important. Secondly, we need some kind of infrastructure for that. Infrastructure where we can easily move our data sets according to our needs. So, and then we need especially for us analytical services, not for their software integrations with decision support, but services directly to the customers, to us, to citizens. So we need also interpretation service, because the amount of data is huge, and how to find the right evidences to make right decisions. Probably we even may need some new specialities. And of course we need that patients or citizens take more responsibility. So during my few last years, I have been working with Finnish Innovation Fund Sitra, where we have tested all these concepts and different piloting. So we have some kind of understanding what we should do. So once more, data from the sickness is coming to the electronic health record. Then data sets from the other devices, IoT things, sensors coming in other way. So we need to have some common account where to connect the data. This account is not super account where you store everything. No, there is no storage. It's just the rule engines to give consent, to give orders. The similarity of this is IBAN, your international bank account number. You just have to know this number to give someone and they can deliver the money. Why not data? So we created a concept of international human account number, which is a similar acronym like IBAN, international bank account number. So, and you need a security layer around this health account to be secure to deliver the data to different parties. And then you can add to this data set, for example, your genomic data. Or you can take data from registries or other sources. And you can now open this data set to the marketplace. and ask, for example, who can help me? This is my data set. Of course, you need to take into account all these security, privacy issues, and for that, we need something which is not existing yet. We need IHAN. What is the IHAN? I will explain smoothly, but why we need IHAN? There has two big threats in the data world. First is data breaches. Big companies are collecting data from us and selling this data, and most of these companies are, of course, in Silicon Valley. Or there is another threat in the other part of the world, in China, where the government owns everything. They provided social index, and according to this social index, which is scoring everything what you have done in your life, using what kind of websites you are visiting, everything, the total control. So according to that, you get the permission to travel, you get bank loans, or you don't take the bank loan. So the social index is how government controls you. So now we have chance to go to the Silicon Valley model, or China model, or take the European model, where the person is owner of their own data. And we have a very good momentum for that. We have new GDPR regulation. We have also ADAS, which is recognition of digital signature among European countries. And PS2 directive is about payments. So probably you all know about GDPR. And if you look carefully, what GDPR tells us is that by my consent, if I go to someone who has data about me and I give consent, please share my data with this third party, it should happen. But GDPR does not tell how. It tells only that it should happen. So now IHAN tries to answer this question, how we cannot do it. And good news is that we have all technology there. So these are just some components, and there is 10 different positions, starting with your identities. You may have different identities. You need to have some kind of identity wallet. Then you should have some consent registry where you give your consent. Then secure data exchange between providers, some kind of certification body who will certify your service or application against these IHAN principles, and so on and so on, and logging system and everything. So all these technological components are there, and Citra, together with the European Standardization Committee, has started this development of this standard. And it will be like a soft standard. It does not tell what kind of technology you should use, but it says that this is the minimum level what you have to use. For example, you have to use strong authentication. You have to use. You have to store the logs. Using blockchain or other technologies. That's your opinion. And why it is important? If you look the history about how these 3 layers, and I have also Health 4.0 here. So we started with electronic medical record in 90s, and then health information exchange followed in 2009. And now Estonia moving to Health 3.0, where we have personalized approach to the data. And by the way, in Estonia, the GDPR regulation is in place since 2002 in our legislation. So for us, it's nothing new. We have also infrastructure how to do that, and all other things. So we have done this already for 15 years. So health account is coming next, and then also important to look what is the cost and the time. The most expensive part of the digitalization is equipped all professionals and all services with digital tools. So I give you an example which is much higher than here. Helsinki University, which covers around 2 million of population, now changing their medical record system to the EPIC. Oh, bad choice, but let it be. So they spent 500 million during 5 years of implementation of EPIC to Helsinki University. It's around 250 euros per capita of area. So it's huge investment. It means that next 20 years they cannot invest anything to the e-health. Now Estonia spent 10 million euros to integration, the Health Duo. So it was like 7.5 euros per one inhabitant. And it took some 10 years to fully implement. Now when we move to the health account, there is technology already there. Only thing that we need, we have to agree on the principles, how we share the data, similarly like it is in banking. Or the other example is mobile roaming. So you go smoothly and you don't know what's happening in back office. So there is a lot of agreements and lot of standards. So and the similar should be with data. And the process is faster and faster. I think when we are ready to take these health-free services, it takes only a few years, maybe 5 years, that we have these in place. And many countries have already started to develop these health-free type of services. So now the next level is to connect AI in this ecosystem to guide citizens in to make better choices and have like health coaches. And this is happening somewhere in the future and probably will be even cheaper and quicker than the previous years. So that was my brief introduction of Health 3.0 and how we have managed to come to this. So now, if I have time, can you?
3 minutes.
Yes, please put my. I will take my phone because.
You need a browser?
Browser, yes, please. So, just a brief.
Just wait.
Demo.
Because I have a special.
Okay, so I tried to. Is it okay?
Yeah.
Yeah.
Okay.
To get some kind of understanding what we have achieved in Estonia. So where is the dot?
The dot.
Yes.
So you don't have. Is it this?
Yes.
Yeah. Dot.
And EE.
Yeah.
EE.
E.
So thank you. So this is let's put to English. This is live demo of my personal view to the electronic health record system. So citizens of Estonia can access to their own data and see the same amount data than any professional. So now I have to put my personal ID. Please, numbers.
Numbers. Yeah, it's not a QWERTY, it's an AZERTY. Yes.
Okay.
Go.
And also phone number. So what happens now? I will get now using mobile ID, and I get the message. I will answer and put my PIN code for logging in to the patient record or electronic health record system. So as you see, it's in 3 languages: Estonian, Russian, and English. So let's put English version. You can see it. So very briefly, what I can do. This is my name, my doctor's name, my under 18 children's data, my health summaries in structured way. Also, all invoices. We have one payer system, national health insurance. So every citizen can monitor how much they have used resources. So here is my all history since 2016. I have spent only 1,500 euros health insurance money for my health. So I'm a very healthy person, of course. So another thing here is that I can monitor. So these were invoices, the monitor view. So let's search all. So logbook. Logbook means that I can monitor who have looked my medical records. So here is a lot of I have seen myself, but let's see here. This is 25th of January this year. A doctor of radiology in this hospital have looked my data. This is nurse have looked my data. Family doctor, another doctor. So I can always monitor because only strong authentication is allowed to all users. So always you can trace who have looked the medical records. So there is no anonymous that someone looked your data in the paper. As a person, you can monitor who has looked your data, and you have access to all the data. And of course, if you are not willing to share, you can do managing access to your data. You can step out, you can close your medical files. So this is only for army persons who are going to army, but let's see here. I can also donate organs, make donations, and decide to whom to share my data. Let's say outpatient case summary, for example, here. So I have case summaries here. If I now all these are unlocked to the doctors, if I do in that way, now I lock this particular document to medical professionals. But I get warning that if I do that, I will take responsibility on my side. So I have responsibility of sharing my data, and now the next stage is we are adding genetic profiles of those. By the end of this year, we have around 20% of population covered by the genotyping and pharmacogenetic profiles. And in 2021, we are establishing pharmacogenetic decision support for doctors that when they prescribe, they can also see information about the pharmacogenetic abnormalities of this particular person. So we are stepping into this personalized medicine era. Thank you for your attention.
It's okay.
Yes.
Thank you, Madis.
Yes.